Hi, I'm Dr. Marvin Natovich. I'm a medical geneticist here at the Cleveland Clinic and professor at the Cleveland Clinic Lerner College of Medicine of Case Western Reserve University. And I'm really pleased today to be able to talk with Dr. Mark Korson, an expert in medical genetics and metabolism, who will be talking about a number of metabolic dimensions of autism. Dr. Korson graduated from medicine, or in medicine, from the University of Toronto, and he completed a residency in pediatrics at Toronto's Hospital for Sick Children. He then did a genetics and metabolism fellowship at Boston Children's Hospital, after which, for about 10 years, he directed the metabolism clinics at that hospital, and then followed that with about 14 years of service at Tufts New England Medical Center as the director of metabolism there. About 15 years ago, Dr. Korson co-founded, and he continues to co-direct, the Society of Inborn Heir of Metabolic Diseases North American Metabolic Academy, which is the premier conference for genetics and metabolic trainees in North America. About 5 years ago, he joined an organization called VMP Genetics as its Director of Physician Support Service, and he pioneered a unique consultative service that provides remote assistance to clinicians at about 12 major United States academic medical centers where patients with proven or suspected metabolic disease are being seen. As that organization's director of education, he's developed a number of extremely innovative in-person and virtual educational programming about metabolic disorders for physicians who are not geneticists, as well as for non-physician healthcare professionals who work in metabolism clinics, so that all of them can play a larger role in patient diagnosis and management, especially because of the worldwide severe shortage of clinicians in clinical metabolism. At that organization, Dr. Korson has also directed a pioneering patient-teacher registry and patient-teacher video catalog, which has an aim of ensuring that patient voice plays an important role in educating healthcare professionals, especially regarding genetic and metabolic disorders. So here we are, and we're really pleased to have Dr. Korson today talk for us about a number of informative cases in metabolism that pertain to persons who have different forms of autism. And we'll do this by illustrating several different hypothetical clinical cases. So to begin with, thank you, Dr. Korson, for taking time out and being with us.
Thanks for the invitation.
Yes.
Happy to be here.
Yes, and we'll start with a hypothetical case involving a 6-year-old female who comes to a medical genetics clinic in the US because of her clinical history of unexplained intellectual disability, autism, and hyperactivity. This particular child, who is 6 years old, was born in country X to healthy, unrelated parents after an uncomplicated full-term pregnancy, uncomplicated labor, and vaginal delivery. The child's parents left their country the day after her birth and sought refuge in the United States because of an unstable, dangerous living situation for them in their native country. The baby's perinatal period was basically uncomplicated, and the baby fed well and gained weight. The parents, as I mentioned, were unrelated, and there wasn't any family history of autism, of intellectual disability, or of any developmental or psychiatric condition in first, second, or third degree relatives relative to the proband. The child's only sibling, an older brother, 8 years old, was healthy, and that child was developing normally. At several months of age, the baby developed chronic, fairly severe dermatitis. She never developed good eye contact and had delayed attainment of all of her developmental milestones, especially those relating to language development. She also had a history in the first year of temper tantrums, but was generally healthy otherwise. Sometime during her first year of life, she had workups because of her developmental lagging, and that included torch serologies, which were negative, and a dilated eye exam, which was also unrevealing. A little bit later, the child had a chromosomal microarray analysis that was negative, and she had a head MRI done when she was 2 years old that showed a small brain, but no obvious structural or other anatomic abnormalities. Now she's 6 years old, and her general exam shows this child to be non-dysmorphic and microcephalic, and she's a little bit more than 3 standard deviations below the mean for head circumference. She's on normal centiles for height and weight. On her general exam, the skin showed patches of eczematous lesions of the extremities. She was very hyperactive. She had only very brief or fleeting eye contact and very little social interaction with anyone. At 6 years old, she was not following one-step requests, and there were no well-articulated words that were appreciated during the examination. And so my first question to you, Dr. Korson, is this child's physical exam is notable for microcephaly. Is there any clinical information that you, if you were seeing this child for the first time, would be helpful for thinking through her microcephaly? And in general, what are some ways that one might conceptualize different processes that might cause a microcephaly?
Well, in this case, we're told that the height and weight are normal and the head circumference is small. That's important to know. That's important to compare how the head size is compared to length or height and weight. If they're all small, then you wonder whether is this a very severe chronic nutritional issue? Is this related to some genetic syndrome that really interferes with growth in overall? And in this case, it's concerning that height and weight are doing fine, and the head size is the only one that's not where it should be, and it's concerning that is this reflecting what's not happening in her head? In other words, that her brain is not growing.
And would it be helpful for you to know, in thinking through these different processes, taking it one step further, if the head size was small at the time of birth compared to whether or not it was acquired sometime downstream in time?
Yes, absolutely, because that can relate to the pathogenesis of the disease. If the head size was very small at birth, you wonder about a prenatal onset of disease, which then continues. That is severe and probably speaks to the disease not being very treatable or responsive to treatment, given the early how intrusive it was in terms of showing itself. If the head size becomes small after birth, so acquired microcephaly, that could tell you something about when the brain was affected by whatever's causing the small brain, the small head size, and could point towards what you have to think about in terms of pathogenesis. And finally, I guess the third thing that I would mention is check to see if there is any familial predisposition to the head size. And that relates to small head size and also to big head size in a child. You often our first instinct is to try to put all symptoms together, and they all have a common cause. But sometimes, a child could be simply delayed, and the head size relates to, the parent's head size. So,
gotcha. So in this particular case, Dr. Korson, the child had some very basic testing done initially, as is commonly done, and the child had a complete blood count, a comprehensive serum chemistry panel, and a urinalysis, and all of those tests were unremarkable. What do those data tell us? How do they help us?
It's useful because metabolic disorders are multisystemic, affecting many different organs, and so the way the disorder affects each organ is tells me something about the phenotype, what the phenotype is or what the phenotype is not. So, for example, if the CBC is normal, that speaks against, say, a cobalamin disorder, a vitamin B12, a group of disorders where there's a problem in intracellular differentiation of B12 into its final form, which can give you a megaloblastic anemia. Or there's certain types of mitochondrial disorders where there's an abnormal hematologic state. The electrolytes and the anion gap, if there's some accumulating organic acid, well, that may drop the bicarbonate and raise the anion gap, and that's that. And sometimes organic acidemias are not; they don't present acutely; they present chronically, and so they're sort of simmering in the background. The glucoses, of course, if there's a problem in maintaining glucose regulation, glycogen storage disease, disorders of gluconeogenesis, there's a telltale sign. Liver functions are, even if it's not causing liver failure, you will see it in peroxisomal disorders like Zellweger spectrum, or amino acid disorders like tyrosinemia. Kidney function, proteinuria is the presenting symptom in Fabry disease. It's just that the patient may have other symptoms, but often the first laboratory sign is often proteinuria. And then urinalysis. If the way the body, where the body gets its energy is important. If the body can't make ketones, well, I'll tell that from the urinalysis. If the body cannot reabsorb bicarbonate, a renal tubular acidosis, a comparison of the electrolytes and the urine pH is very helpful. If the patient is talking about dark urine after muscle pain, well, it may show up in the urinalysis as a positive for blood, but when you look for the red blood cells, they're not there. It's myoglobin, not hemoglobin. So if you are discussing a case with a geneticist or a metabolic doctor, I guess I would say show all the tests that have been done, as opposed to saying the workup so far has been negative, because what was done, even if it's normal, is helpful.
So this is very helpful, and if I'm hearing you clearly, that even these very inexpensive, commonly used tests can be very informative and can push us away from considering certain disorders, and thereby making us think of others that now may be more likely. So in this particular clinical context, Dr. Korson, given these negative tests, and given that the child has intellectual disability, autism, hyperactivity, and disproportionate microcephaly, what would a metabolic consideration be running through your head? And if so, what would be some first-line metabolic testing that you, as an expert in the field, would consider?
So let me get this straight. You're asking a metabolic doctor, should I be thinking about a metabolic disease? I see the whole world through a metabolic prism. But the answer, of course, is yes. Forgive me, I want to back up a bit.
Yeah.
And I want to talk, just as a preface, about the way diseases present, the way metabolic disorders present. The dramatic ones like urea cycle disorders, or organic acidemias, they present acutely. So the patient could be fine one day, and then next week has a clinical biochemical decompensation, very sick. Then there are some cases where there's a chronic state, like as in this child, where the patient doesn't fall apart during infections. It's just the symptoms are always there. And then there's acute on chronic, where you have this background state of something's not right, and the child also decompensates. That could actually be a severe urea cycle disorders, acute on chronic. Late onset, the patients are actually fine between episodes, but then get horribly sick when they get sick. In this case, I think we're talking about a chronic disease, so a chronic disease course. And so, given that this child has autism, intellectual disability, seizures, so the first thing I would do is I would always check to make sure that a complete review of systems has been done, because by far that is the most sensitive and cheap metabolic screen that we can that can be had, and that really helps characterize it, defines the phenotype, so nothing is missed. So again, if the simple tests haven't been done, I would get a CBC and differential. I would like to see what the bicarbonate, what the anion gap looks like. I would like to see if there's any liver dysfunction, renal dysfunction, lactate. Homocysteine is very useful, not just for homocystinuria, but also for some disorders of cobalamin metabolism, or associated with cobalamin metabolism. And of course, urinalysis. Metabolically, there are a number of disorders that can present in this way, and I would make a pitch that everyone deserves a diagnosis, but what you never want to miss at the end of the day is a treatable disorder, where you can intervene now and prevent further problems down the line. So, speaking for screening in blood, we would do blood amino acids. We would do blood acylcarnitines. We would screen for a group of disorders, carbohydrate deficient glycosylation disorders, because there are a number of treatable disorders among them that we've discovered. I would get thyroid function tests if they've not been ordered already. And then from a urine perspective, urine organic acids, I would screen for creatine disorders, creatine synthesis disorders. I would also get urine glycosaminoglycans. And am I missing anything? I think it's a good place to start. And the other thing one should decide, I know that an MRI scan was done
when the child was about 2 years old and showed microcephaly without any apparent structural anomalies.
So we have 4 years of brain growth since then, and brain development. Is there going to be any sign now that something's going on in the brain, which could be helpful for diagnosis? I would probably request a follow-up brain MRI.
So in this particular case, Dr. Korson, those tests were done, and the plasma amino acid analysis was flagged. And it was flagged because the amino acid phenylalanine was extremely high. It was 1,200 micromolar. And the blood amino acid analysis also showed that a related amino acid, tyrosine, was low at about 20 micromolar. As a expert in metabolism, can you tell us what those data tell us, and if there's any additional diagnostic testing that would be useful at this time?
A couple of things. One is, phenylalanine and tyrosine are related amino acids. Phenylalanine is an essential amino acid.
What do you mean by an essential amino acid?
It means that the body cannot synthesize its own phenylalanine. Phenylalanine must be obtained from the outside through diet. And then it's converted to tyrosine. So tyrosine is a non-essential amino acid. It seems here that something between phenylalanine and tyrosine is not working. And it could be that the enzyme phenylalanine hydroxylase is not converting phenylalanine to tyrosine, or the cofactor that the hydroxylase enzyme needs is either not being synthesized or being regenerated or can't attach, or something's wrong with a cofactor.
Can you explain what a cofactor is?
A cofactor is some vitamin that is used to enhance or make possible enzyme function, enzyme catalysis, but it's a necessary component. And not all enzymes are like that, but certain enzymes use it. And that's an added opportunity to consider diagnoses and also to treat the patient. So in this case, is there an enzyme problem? Is there a cofactor problem? It would be the major concerns. As a result of the defect, phenylalanine is high and the product tyrosine is low. That combination suggests a diagnosis of PKU or phenylketonuria. And what's interesting to me is I don't see these cases anymore, by and large, not in this country, because newborn screening since the 1960s has been screening the general population, all babies for PKU. So it's such a case where a child comes from another country where newborn screening wasn't done, or the patient missed newborn screening, and we see the unfortunate complications down the road.
So let's play out several different scenarios. Had this child had newborn screening, what would the general and the specific types of treatment have been, and the natural history generally have been with those types of general and specific treatments? And now for this particular child who's 6 years old, who was not having had newborn screening, what would the general and specific types of treatment be, and how would that more likely than not play out over time?
Well, if this child had been screened in the newborn period, and they identified the biochemical abnormality, then the patient would have been referred to a metabolic center. The diagnosis would have been confirmed with additional amino acid testing, and the patient commenced within days after birth on a low phenylalanine diet. Now, I call it a diet. It is not. There's nothing easy about it. It's you have to take a special formula that is has all the tolerated amino acids in it, but it has no phenylalanine because that's so limited. The patient needs a certain amount of natural protein because you need a certain amount of phenylalanine to grow. And then the parents need extensive counseling and support, and they become best friends with a dietitian. And then that child is monitored and followed really for years and years. But if the parents are able to do that and are supported well, that child can really show normal development. And in this case, the parents didn't know that there was this kind of problem. And so at 6 years of age, there are real problems here in terms of what we can do. The formula that PKU patients take is vile tasting. I mean, there are attempts to add flavorings and stuff. It's not easy, and the diet is incredibly intrusive. And the truth is, patients don't stay on the formula forever. They just can't. It is not compatible with a long-term treatment plan. And so there are all kinds of alternatives being developed now. So it tastes vile. You can get any baby to start taking vile tasting things before the age of 6 to 8 months. They just will take, I mean, if you've ever had ordinary infant formula, it doesn't taste very good. But when babies get it from birth, they're fine. After the age of 8 or 9 months, they develop a sense of taste, and they will choose what they like, and they will push away what they don't. By the time they're 6, good luck if you're going to be able to get a child to take that kind of a formula. And given that patients with autism have very particular dietary preferences, I'm actually concerned that trying to put a child on that kind of a diet will actually trigger behavioral outbursts. And I don't think, and even if you could get the child on the diet, you wouldn't be able to reverse the brain damage that has already occurred. What you might be able to accomplish is make the child's behavior come under better, more easily manageable, and maybe make it easier for her to learn or grasp, training opportunities. But you're not going to achieve anywhere near normal cognitive development. What you might be able to accomplish with diet is also her skin condition, what it will improve. And in fact, I was going to ask a question right after the history, is often the rashes, the eczema-like rash that occurs in PKU, it doesn't respond to the treatments for eczema. So asking whether or not that the rash did respond to therapies, if you get a no response, then you really wonder what is the cause of that skin rash.
That circles back to your point about taking a meticulous review of systems.
Right.
Yeah.
So I don't think starting treatment at this point, even though it could provide some benefit, I think you really have to weigh the benefits and the aggravation that you're going to be starting.
So in this particular hypothetical clinical case, the family was in an unfortunate situation where the parents and the children were refugees, and this particular child who comes to your clinic never had newborn screening. Can you briefly give us an overview of newborn screening around the world? What is the state of newborn screening? Is it similar across the board in all countries? Is there a lot of variation? How much variation is there in the United States? How easy or how difficult is it for a child to miss newborn screening here or elsewhere?
Wow. That's a huge question.
Yes,
but,
I know.
So newborn screening in countries with advanced healthcare systems, which tend to be the richer nations, have more extensive newborn screening programs, so screen for a lot more disorders. In the United States, that could mean screening for several dozen disorders at birth, most of them metabolic. It varies within the United States because each state is mandated to determine which disorders are screened for in that state. So it varies from state to state, but all states screen for PKU and probably a set of core diseases. In Europe, there isn't generally as aggressive screening as there is in the United States. But one can assume, as in the United States, there is going to be funding available to support further diagnostic tests, treatments, and monitoring. And so the patients have, it varies, but patients have better outcomes if they're identified by newborn screening in such countries. Then you have lower and middle income countries where these countries are obviously not as wealthy. And so there is inadequate funding to support diagnostics, monitoring, treatment. There are often not enough trained professionals that even if you do diagnose a PKU patient, there isn't a clinician around that can follow up that patient. And those patients need years and years of follow-up. And these countries are still in their own healthcare evolution. So when countries adopt or take on the responsibility of newborn screening, it's usually means that they've been able to bring down the infant mortality rate below an acceptable level where it makes financial sense now to start screening newborns. We in North America haven't thought about that for decades and decades and decades, but other countries are sort of getting to that point. And then there's a bunch of countries who are they're really trying to get by and have all kinds of problems, healthcare and social and economic, and where newborn screening just doesn't make sense. In those countries or lower and middle income countries, newborn screening is done on a very limited basis for wealthy parents who choose to have the test done in another country. And if a child is identified, then that child might be seen by clinicians in another country. But obviously that's not a universal solution. And so if you in your practice are seeing a patient from another country, it's worth asking or finding out what the child was actually screened for, because you can't assume anything.
So you're driving at, in addition to taking a meticulous review of systems, to take a meticulous social history.
Oh yes, well, absolutely. And just because, especially with children coming from other countries, adopted from other countries, what was the social situation there? Were they in orphanages? What was the care like? What was the nutrition like? Again, one can't assume. And there are studies, or there are reviews that that can give some light onto what were the pluses and minuses of newborn care, like in a particular country at a particular time. But in general, it's, I think, very important to ask questions about the family unit, who are the caregivers, what are the dynamics, how did the child socialize at home and socialize with others, what happened in the child's early formative years can be very helpful for interpreting a child's development, a child's behavior, a child's learning potential.
Dr. Korson, the particular case that you so nicely went through today involved a child who has phenylketonuria, who unfortunately did not undergo newborn screening. But had this child undergone newborn screening and received appropriate medical care, it would have been a treatable metabolic disorder that without treatment has resulted in intellectual disability and a form of autism, and other clinical sequelae as well. So my next question to you is are there other examples of treatable genetic metabolic disorders that, if untreated, can result in intellectual disability with or without autism?
Well, the answer is absolutely yes. And there was a wonderful study. Van Carnebeek was the senior author. It's 2021. And I'm going to suggest this as a resource, as an educational resource. It's called Treatable Inherited Metabolic Disorders Causing Intellectual Disability. It's from 2021 in the Orphanet Journal of Rare Diseases. And it goes through the 130 disorders associated with intellectual disability that are treatable, that you don't want to miss. And obviously, it's great to get in before the child is burdened with the intellectual problems. But for many of these disorders, even if you intervene late, you can make a difference. So, the useful thing about this particular resource is there's also a phone app, which makes the resource more usable at the bedside or in the clinic. And so the app is treatable ID. It can be searchable by treatable ID.
That's really helpful to know. Thank you so much for going through this case and teaching us so much about this particular set of issues.